We will begin our journey into other people's frames of reference with a panel of experts on the economic costs of health inequity. To lead the panel, I am pleased to introduce Jay Bhatt, a practicing primary care physician and executive director of the Deloitte Center for Health Solutions and Deloitte Health Equity Institute, and a member of the National Forum's board of directors. Dr. Bhatt?
Hi, everyone. It's great to be here with you all at the annual meeting of the National Forum. John, thanks for that kind introduction. It's just been an honor and privilege to team with you and the National Forum leadership and community and advancing health equity, and that's the topic of our conversation today. It's health equity has become a really hot topic over the last several years, illuminated by the inequities shown through COVID, as well as social unrest, and also increasingly the issue of the business implications. So we know that health equity is not just a moral imperative, but it is a business imperative too. And I would say that health equity is America's chronic condition. It requires upstream action and investment. So we've got to stop putting on the Band-Aid and think about systemic and structural actions that can help us towards a better future. And joined today by my colleagues from Deloitte, Neil Batra, who's a principal, as well as Andrew Davis, another principal at Deloitte, who are co-authors of this report released by Deloitte recently around health equities and the cost of health inequities. I'm also joined by Margaret Gervin Calvert, Senior Managing Director, President, Center for Healthcare Economics and Policy at FTI Consulting. So really excited to have this discussion today. This panel will address how health inequity costs average Americans and how much. How does health inequity affect the middle-class family in the middle of the country? Or does it connect to the priorities of people whose top concerns are inflation, the economy, crime, or climate change? And so we'll get into some introduction to the topic in the report that was released earlier this year, and then get into a Q&A with our panelists. So let's get started. So I'll start with Andy Davis. Andy, according to the cost of health inequities, in the report it says health inequities could cost the average American at least $3,000 annually, up from today's cost of $1,000 per year. That makes it really personal. But I'd love for you to share how you got there. Why was this important? What was some of the analysis, and what were some of the conclusions from the report? And invite Neil certainly to add additional commentary to that as well.
Yeah, Jay, thanks. And again, excited to be here and share this. And if you don't mind, I'm going to pull up some material because I think it helps explain, how we got there. Because I think it's a really important journey that we had as we were building this model. I'm going to flip to the next slide. And one of the really interesting things, Jay, is Neil has been leading this. I've been a part of this team, our Future of Health team, Deloitte's perspective on the future of health and where we expect it to be in 2040. And we had published and built a comprehensive model around what advancements are going to do as we think about the future of health to overall healthcare spend. And what we found as we looked at that is that our current trajectory of spend, which everyone projects to be at around, hovering around 5%. When you look at everything we're investing into the future of health, there's an amazing potential to move over into that far right-hand column and actually start to bend the cost curve down. So instead of running at 5.3%, you're running at 3.7%. And what's interesting is if you capture the delta over a period of time, what you end up creating is about $4 trillion of what we had called in that model the well-being dividend. What we didn't capture and what was really important and why we built this model is there is one very critical assumption, and you called it, there's an equity and bias as America's chronic condition, is the fact that we believe we actually have to be able to make progress on health equity. We have to be able to reduce the systemic bias that we have in our healthcare system. And so we wanted to make sure we understood how big is that number? What is the order of magnitude we're solving? How much waste sits in our system today? And what we found is that as we built this model out, in the middle is the rate of growth of health inequities. And these come in multiple forms, right? So at 6.2%, it's a big number. We're gonna unpack a little bit more of those numbers on the next page. But there is a few different things that sit in here. One is there is truly a difference in some of the care and bias that individuals have. Now, when we did this, we looked at racial and ethnic bias and inequities. We looked at gender bias and inequities, and socioeconomic as well, because it was the first report that looked at all three of those numbers, and we thought it was important to hit on the types of things that we're seeing. And each one of those populations has different, whether it's variations in care, science that is perpetuated over years that creates waste in our system, or even a lack of trust. All of those things are included when we talk about this rate of change for inequities. And I'm going to move to the next page. I'll talk a little bit more, and then I'll pause for my colleague Neil to join in as well, because you hit on a couple of things that are really important. As we built this model, we had to start with the bottom up. We took multiple disease states and said, what is the difference? And when we actually talk about $320 billion is the difference in the cost of inequities today, that's not a reflection of great care. That's a reflection of the gap in care. So one of the examples that we have in the model that we went deep on is the rate at which a non-Hispanic Black population gets colorectal screenings relative to a non-Hispanic white population. The difference is 60% for the first population, 65% for the non-Hispanic white population. We're closing the delta. If I got 5% more of the non-Hispanic Black population screened, what's the savings in catching cancer early? Because too often we're finding cancer in late-stage disease for the non-Hispanic Black population, perpetuating what we would call waste in the system. That's the dollar amount that adds up to $320 billion. And just to give you a sense of how much waste that actually is in our system today, that's 8% of what we spend on healthcare expenditures today, just to close the gap. But we also wanted to show that this actually isn't a problem that in today's world is big. It continues to get worse. So as we actually projected this out to 2040, we get to a number that is $1 trillion, right? $1 trillion, that's going to represent about 12% of what we think the healthcare expenditures could be, which is just a significant number. But you hit on something that is really important. Oftentimes, this number gets translated into who does this impact? Well, this impacts every single individual to the tune of it's $1,000 a person in today's world. It's $3,000 a year a person in 2040. That is $12,000 for a household of four. That's what I thought about. I live in a household of four. And so to me, that's an amazing number when you think about the actions we have to take in order to solve that, because that's something that every single household has a role in funding and paying for. And I think that order of magnitude is big enough to where it calls us all to take action. Neil, what would you add to that?
Yeah, a couple things I'd add to that. And Andy, I thought that was a great sort of summary of what we did to get to these observations. Couple thoughts. One is, if you're in a community that has women, that has those that are on the lower half of the socioeconomic continuum, or you have non-Hispanic Black and brown populations, this bias is showing up in very real ways for those in your community. And to Jay's opening statement and point, these are systemic and structural in nature, in the sense that these aren't necessarily overt acts of bias, but these are elements and dynamics of inequity being created through the way in which you engage in the system, navigate in the system, those you communicate with and the responses to it, and how it links to the care you receive, the information you receive, the access you have to systems, right? Lots of underlying dynamics in terms of the nature of the bias and the inequity. The point is, this touches everybody. And that's why I think we were very comfortable coming out with an annualized per capita, per individual number, is because we genuinely believe if this is impacting anyone in your communities, it's being spread across your community from a cost-bearing perspective. So it's big for the average family. It's enduring, and it's getting worse, to Andy's point. And for us to realize the benefits of the future of health and the narrative that we've been sharing around earlier diagnosis, earlier intervention, spending more time being well versus unwell, and beginning to evolve our system from a sick care to well care system. For all of those things to happen, we cannot have this bowling ball weight dragging us down on the transformation in the form of these inequities.
Andy and Neil, thank you for that. That I think helped frame up the findings in the report and what's at stake. And you, Neil, I wanted to just double click on your perspective on something you provide significant leadership on at Deloitte on the future of health. And you alluded to some of the characteristics of the future of health, but want to see if you could expand on, what are the particular levers and how do you see the evolution of the future of health occurring as it relates to where there's opportunities in trying to address the
the future of health in a nutshell, I would say, is about this evolution of moving from a reactive sick care system to one that operates very differently with incentives that reward those for operating differently. And the operating differently simply means you don't wait until someone's deeply unwell to then bring them into a system and then require really complex navigation to get them really complex and costly care. Right? That's one way to fix a problem, is to wait until it's a really complex problem, and then you engage in really expensive and complicated ways. You could solve problems that way. Probably not the best way to solve problems. So our view of future of health is we're going to go after the problem much, much sooner. And you're able to do that in this generation, in part because of the activation of the individual and the fact that there's a level of health literacy and there's a level of health awareness and activation where consumers are beginning to really take in information, self-navigate, and they're empowered, and they have lots of digital tools. And the other side of this is we have the data and the analytics and the diagnostics that allow us to actually see disease emerge or complications and health issues emerge much, much sooner than folks may actually understand them to be emerging on their own. And so when you couple those two things, the activation and the earlier line of sight, the mechanism that we believe is playing out here, and this is something that's happening in some ways naturally, not sort of artificially, being driven by any one enterprise or one agenda. This is happening. You have folks wearing wearables, you have better diagnostics, you have more activation at the individual level. All of that is leading towards more engagement around emerging disease sooner. And if you can do that, the way to go after disease when it's nascent versus when it's really complex, the cost differential isn't a 2-to-1, 3-to-1, 5-to-1 savings. At the extreme level, sometimes it's 1,000-to-1, 10,000-to-1 difference. And when you extrapolate that across all therapies, all interventions, we actually believe, and this is Andy's point around the $4 trillion wellness dividend, we believe the cost savings to the U.S. system are massive at a macro level and at a micro individual family level.
That's tremendous. I think that's such an important view to relate to where we need to go and what are some of the systems and structures that can support that, and the policies around the future of health is a view on a care model, and then the payment and incentives that support that care model. So Meg, I want to come to you on your reaction. Basically what Andy and Neil are saying is that health equity isn't trending towards crisis. The cost of health inequities, in fact, isn't trending towards crisis. We're in crisis now. What's your reaction to what Neil and Andy have shared?
I think what Neil and Andy have framed up is exactly the right way to be thinking about it in terms of looking at and really putting an effort into understanding the drivers and the connections between poor health inequities, and the overall total impact, not only on economic prosperity and on growth and resiliency, which I think proving that connectivity and trying to quantify it is critical, but also then, as they were each suggesting, looking at the drivers. And as I looked at those slides that Andy shared, that's exactly the framework I think that we've seen applied at the local community level that is really starting to drive understanding and action. So one of the things I would share in our work, for example, in the center, as we've been working with stakeholders in communities such as Buffalo and Nashville and others, one of the things that is really helpful is to understand and to quantify, for example, what is the total cost of a health condition such as diabetes or obesity or hypertension, and to create and share those data in what one of my colleagues, Dr. Mike Kropp, who's CEO of Independent Health, has called connection data, which is making it real, quantified, and locally relevant. And so there, for example, one of the things that I think is useful is to think about, as you were saying, that per capita cost, not only of what does diabetes entail across the community for medical service utilization, and put that in an individual level, but also show the total productivity costs and the economic tax on a community, which in some communities actually can be in the billions of dollars annually that are foregone or lost that could otherwise have been deployed. So I think this framework of looking at and trying to understand what are the drivers, what are the costs. I think the other thing I would say is the idea of taking the time now to be thinking about what's the impact in my community, what's the relevance for me, is really understanding, as you all have been saying, that the trends are not moving in the right direction. Research, for example, that we've done on 140 major cities shows that the prevalence of hypertension, diabetes, obesity, depression, other chronic conditions is increasing, and that in over half of those areas, there's significantly higher prevalence rates for African American, Hispanics, and other vulnerable populations. So those are critical conditions. Food insecurity, life expectancy, other metrics are really also factors, that are critical trends. And let me close with a statistic that I was startled by is the CDC came out last week with a national set of statistics showing that the rates of adult obesity for African Americans as well as adults overall, the prevalence of that of 35% or more of adults in states has doubled since 2018. So those trends, the importance of acting now and finding ways to act now, Jay, I would say is really the vital takeaway I would have from the research that Andy and Neil shared.
Meg, thanks for your reaction and comments. And I think to your last point about obesity, there and to the point that Neil Andy made around drivers of health, and as a clinician, I see people going back to the conditions that make them sick. So one of the recommendations we talk about at the work of the Deloitte Health Equity Institute and at Deloitte is thinking about how we address local, social, economic, environmental drivers of health through place-based coalitions. So where a person lives in their geography can dramatically affect their chance of living a longer, healthier life. And, this idea of zip code being more impactful than genetic code. But one of the other things that the report touched on and talked about was the reality that addressing health equity can grow consumer spending, fueling the national economy. And when you have people be healthier and they're not sick, it impacts productivity in jobs as well. And when we look at the issue of that Neil raised around women and people of color that face biases that can lead to delayed care, misdiagnosis, medical errors, and limited access to best treatments, addressing health inequities and some of the actions that we'll hear more about and Neil talked about could help reduce the cost when you prevent or eliminate and reduce bias. And so this, I think, future of health approach can really be an important anchor in trying to advance the issue. Now, I wanted to go back to Andy and say, you talked about some of the excess costs. How might an average American recognize the impact of the excess costs on their household? How do they, in your view, based on the findings of the report, can make this real? And would invite Neil to comment on that as well. And then we'll go to some of the actions that the report suggests.
Yeah, Jay, I think that was one of the critical questions, right? I think the way we see bias typically showing up is the cost on that individual patient, right? But I think even the number that we just quantified within the report, which I love, Meg, the way you had framed that. There's so many other economic burdens that we see, but the cost and the waste associated with inequities, everyone is paying for in some way, shape, or form. For the patient that's subject to those, the cost sharing that they might have for that additional care, that visit to an emergency room because they have unstable housing. For others, it shows up in their employer premiums, right? Because as a health insurer, as an actuary, by background, working with insurance companies, that you're covering some of the risk and the waste that sits within our healthcare system. And by the way, those end up showing up when you look at Medicaid and Medicare populations, which are heavily subject to the biases and inequities that we quantified. That also shows up in the taxes that we end up paying, both at the state and the federal level. And so what you end up seeing is it's everyone is paying for the fact that we need to take action right now to prevent the growth of this number and actually hopefully make it go down. That doesn't even touch on the areas that everyone is paying for it, Meg, to your point around all of the other things and the economic burdens and impacts that we see within our economy that are above and beyond what we see for healthcare expenditures.
Great. Andy, I think that's well said. And Neil, would you any other perspective to that, from your experience and work?
Yeah, a couple thoughts I'd add on to it. One is, the headline narrative here that probably sits above the report is that, unfortunately, given the way incentives have been aligned within the U.S. health system, bias has been profitable. If I treat you poorly and you come back and require additional care on the same incidence, same issue, I make money again as the health system and as the provider in trying to treat you a second time and maybe a third time. Not to say it's being done, again, overtly with intention, but based on these structural dynamics or based on some of these inequity elements that have not been addressed, you have this actual artificial revenue being generated in the system. And so until we have incentives and pressure from the broader community to rip these biases out and have organizations go after these structural dynamics with real intent, my concern is that this number, while in crisis mode now and significant now, will continue its upmarket march to the larger and even more concerning number. So if you're the average individual having to listen to this discussion, I think this is a call to your congressperson to say, bias is everyone's problem. Get it out. I don't want to carry the bag on that inefficiency in this system. And I think you can start there because so much of this is embedded. It really is very hard for the average individual to exert influence on the system and affect this at an individual level. You have to put pressure on the overall policymakers who then can put pressure on the enterprises to go after this with real intent.
Yeah, I think that is an important point that, the system's perfectly designed to achieve the results it's designed to get. And, until we make some of those changes, build capacity and understanding for, how to address the bias that's showing up, then we might not be able to make the progress that you all are calling to action here. Go ahead, Meg.
I was going to say on a kind of following up, Neil, I think on a somewhat encouraging note, I think what the pandemic has wrought in many communities is greater activity by civic and community organizations, and also bringing more stakeholders to the table that traditionally are not at the same table in terms of faith-based organizations, along with health systems and health plans and public health executives, but importantly, more businesses as well, that are really looking at and understanding the significant impact of these disparities, that chronic conditions are more prevalent, that access has been an issue, that there's a lack of trust in the system. And so I think there are some elements that have now been aligned to move more in the direction that you've said, to really try to use these trusted relationships to look back in and say, well, what kinds of actions can now be taken? Yeah, perhaps to look at access, to look at food insecurity, and to also be able to understand what is the impact on the community if there is not collective action that's taken to address, to recognize that it's a community problem that has impacts on everyone within the community. So that's where we're seeing, for example, and I think there's also been significant adverse effects on populations. In Buffalo, for example, there was a disproportionate rate of mortality due to COVID because of underlying conditions and many other factors. That was addressed. So seeing some of those successes maybe then caused Jay to go back in terms of looking at those social factors, what else could be done, but to reframe it to show the return and the benefit and the savings that come from that collective action, to be outside the walls of the hospital or the clinic and in the community.
Yeah, Meg, thanks for that tee up. I was going to go there in terms of, health equity is everyone's business, and that one of the things that the report suggests is cross-sector collaboration as a critical lever for impact and action. And we think about this in 4 domains of action. So organizationally, what are you doing within your own house with your policies and programs and your people? And then what do you do with your products and services to look at through a lens of health equity? Are you contributing to a health footprint or taking away from one? And then what's the action as an organization that you may take in the community? And then in the ecosystem, which includes policy and other actions. And what I see is, for the first time in my lifetime, an alignment among stakeholders as it relates to health equity. So there, I think, is enormous opportunity to make progress on this issue. And so I'll come back to Andy and Neil. Maybe Andy can share some of those 5 actions that the report suggests. But Andy and Neil, if you could share some examples from your experience in the market of how organizations are thinking about this from an economic standpoint and their people, and then any products or services that are going through a health equity lens.
Yeah, I'll start, Neil, and maybe you can chime in, and I'll get specific, Jake, because I think it's important. To your question, I think we're, or at least the timing, I think we are starting to see organizations working together. I had the opportunity to work with an organization that was focused on the West Coast. They were looking at maternal care for their Black and brown population, and I think they had a whole bunch of, over the last 2 years, developed a whole bunch of initiatives trying to make sure that they actually could try to get care better for those individuals. And what they found, and I think this is how you realize we're at this tipping point, for them to be the most successful. This was a health insurance carrier. They had to engage the health system, the clinicians that are touching those patients every day. That wasn't enough. They had housing instability with some of the population they were trying to serve within a metro area. They had to work with community organizations so that, and so what you've found for the first time, for them to have an impact, and then their measurable impact was, I want to reduce complex deliveries and preterm birth, right? Which is, we know has there's such a significant disparity between the average white population and a Black and brown population, especially in this metro area. They had to work together to solve that problem. Alone, the health plan couldn't do that, but they could work with provider organizations. They could work with housing communities. And to me, that's a really important note about one of the actions that we find is most critical is that I think for multiple years, health equity has been something you try to solve by yourself. I'm gonna work within my own function for my own employees, and then the products and offers that I have. And Jay, you hit on it. That's really important. There's no way we actually touch the continuum of care and all the ways disparities ends up manifesting if we only stay with the products and solutions and services that we offer. You have to be able to extend beyond and work within the community with every other stakeholder who's touching that patient or member or consumer, depending on where you hit them within the life cycle. And that's super important. And that's one of probably the most critical actions is finding ways to engage every single stakeholder because it's everyone's problem. And we actually won't solve it without everyone at the table. What would you add?
Yeah, I'll add another example, maybe from a different stakeholder in the ecosystem. So I'm working with an employer right now who took a look at the paper, who took a look at our social determinants of health framework and said, what can I do for my employees that's not just on the back end of care in terms of, hey, let me make sure you have the right network. Let me make sure you have the right types of visits covered type of thing. How do I do better for my people? And so we dug into the profile of the employee mix. And, in every organization, there's a percentage of folks that tend to be in more of the support and infrastructure roles that may not be the ones you think about when you think about your employee base, employee mix. In the case of this organization, it was folks who were in the warehouse working in the manufacturing plant. It was admin and support staff. It was janitorial and cleaning services. It was those populations which have very different socioeconomics. They have very different health profiles. They have very different racial profiles that tend to skew more towards Black and brown populations. And so we actually decided to run a number of pilots for those populations. And we're trying some things with this client. So they elected actually to take their most at-risk folks who tend to have the worst health outcomes over the handful of the last 5 to 10 years. And we gave them wearables. And we said, hey, could some of these wearables, one, elevate health literacy and awareness, give them data that's translated into actions and insights for them, and also potentially prompt awareness of emerging health issues that would then move them into the system sooner than they would self-present or when they would have an incident that would actually push them into the system. Now, we don't have the returns on that pilot just yet, but it gives you an example of how if you're going to go after this problem, it's not the classic system with the classic levers doing the same stuff, right? I don't think this is around, for employers and the benefit managers. It's not about network, right? That matters. And of course, you got to get that as right as possible. It's about doing some things that sit in front of it that you probably haven't done historically and getting down to the individual dynamics that make this such an intractable, complicated, challenging issue.
Yeah, and Neil, to pick up on that, that cities and counties and states are employers too.
Exactly.
And
right.
that the costs can impact them in significant ways and crowd out their own budgets, as well as impact productivity. That we're already, in situations where there's infrastructure and workforce challenges within government and the public sector. Getting sick is not going to help that. And when we look at, some of the data, people living below the federal poverty level are more than 50% more likely to have asthma than people earning higher incomes. And according to the report, those disparity-driven costs equate to 4.3% of total spending on asthma, equivalent to $2.4 billion per year. That's a significant cost to stakeholders. So, Meg, I'd love to hear if you've seen places where that some of those government players have taken steps to address health equity, within their community. We see in our work where we work with place-based coalitions like the Greater Washington Partnership and others, where they're making substantial progress towards inclusive prosperity and addressing health inequities. But I think given this audience, that would be helpful.
Happy to address that. And I think to kind of echo a couple of themes that you and Neil just touched on is one of the most innovative approaches that needs to occur is breaking down the silos that we've historically had between it's a public health issue, or it's a healthcare system issue, or it's a business issue, or it's a civic issue. And I think one of the things in a couple of the examples I'll share is really where those silos have been broken down. I think the second theme I was hearing that we hear a lot is that it's important for business community health leaders to think of it not just as a cost of doing business or a public health issue, but really the need for an investment in their community, in their people, the future of their business and their community. So I think that kind of reframing that we're all talking about is important. And to go specifically, what we saw in the Western New York area, Erie County, Buffalo in particular, when this issue was brought forward by Pastor George Nicholas of the Health Equity Task Force to the county, that there was a disproportionate mortality rate from COVID. There were access and other issues. What the county did was really to bring together an entire collaborative of stakeholders, community organizations, others, but also to take on the responsibility to go out and find the data, which was typically not available, collect the data and share it with the community in a way to show what was happening at the zip code level, where there was more predominance in particular zip codes of health equity, health disparities, but also impact. So, and then putting through follow-on policies, looking at how to improve access, improve food security, housing, and other grants, but also then to go, I think, to the other answer is not trying to do it all themselves, but to engage with community organizations to take on more of the activity. And that, I think, is what has come up with, more initiatives. The other thing I would say where I love the idea of these pilot initiatives is I think the two things that we really need for greater success is more sharing on which are the interventions that have been most successful. We've seen Nashville schools, for example, really take on obesity, health disparities related to obesity and actions as a self-funded insurer. We've seen other studies looking at it. So I would agree, I think, trying to share that. The other thing I'd be interested in thoughts on, and why I kind of come back to the Buffalo area and to other areas, is this idea of having an anchor institution who's going to be there in the community, aligning people, for what you all are talking about is something that needs to be there this year, next year, the year after, the 5 to 10 years you're talking about. So that is the other thing I would say that we see starting, Jay, in some of the communities, that there's different kinds of anchor institutions, but one's coming to the fore.
Jay, you may be on mute.
So I was saying thanks, Meg, for those comments. And I wanted to ask Neil and Andy if anything in particular resonates from what Meg just shared and how it relates to the conversations you're hearing in C-suites and boardrooms. Because I would say that health equity and work around that can change the basis of competition. I think.
I absolutely agree with that. I think make a lot of interesting nuggets sort of in your commentary. One is I love the notion of sharing learnings, and I think as organizations experiment more, I think the need to publish that, share that within the community, urgent and critical. And my sense is folks get that, and you'll be seeing a lot more of that in the written narrative. I think in the public domain here over the next coming years. I think your point around the institution and the anchor institution is a great one. What's important for us to consider, I think, is we've made the point that this is now a front of the page, top of the house agenda item. Our view, and we believe this, It is certainly now a board level discussion that has some consistency and some stickiness. I think what we can't do is mistake the stickiness of the moment with permanence, which is why I continue to argue for more pressure from more voices, and a consistent drumbeat of expectation here. Because if this was so self-evident, the communities would have been there already, right? But this is a recent phenomenon for lots of reasons that we know, not the least of which was the George Floyd event, and the summer of marching all across this country with real consistency, real scale and size, and a real diverse population showing up for it, right? Those are really critical dynamics that has elevated this to a level where it's gotten some quasi-permanence. My concern is, will it have true permanence? So I think the large institution idea is a fabulous one. Who is that, and how do we, determine how they have stickiness? I think is a big question. And how do we support those organizations, reward those organizations, promote those organizations, so that this does turn into a basis of competition issue, Jay, right? It matters in pockets. Consumers continue to care about it more and more. You have more information where there's some transparency around how organizations act, and are they good actors, mediocre actors, or bad actors, on this topic. All of that needs to be more and more consistent, in my view.
Maybe I think a couple of things that both Meg and Neil, to pick up on something. I think Neil, to your point around the drumbeat, I think one of the reasons why the report, the numbers that we've created has been helpful is, Jay, you opened here as not just a moral imperative, it's a business imperative. The reason why boards can pay attention now is you can actually go with use cases and show it's not just that we're solving clinical care. This can actually help save money, right? And whether you're an employer group, whether you're a health insurance company offering premium, whether you're a provider in value-based care, everyone can serve in a way to benefit from the fact that there is waste, that we have the ability to take action. Mm-hmm. I think that's super important. What's been challenging for organizations, and Meg, you had talked about data, which I love, is how do you actually get data at the level and the grain that you need to in order to measure success, and where do you start? Because I think the conversations I've had with organizations as we've been moving forward is they oftentimes start with, I think, the ideal outcome of what way they would like to influence, right? And then they try to hold themselves accountable to that metric, which is great. They have no way yet to measure that. So even just collecting the data is a Herculean effort that I think we need to make sure that we recognize it will take time to get there. So my advice is also to start on measurements you have today, where you can break that data down, and then progress towards the more meaningful outcomes-oriented metrics, because we're going to evolve there. And I think oftentimes, at least I know, working with health systems, working with health insurers, they're trying to build metrics that are almost impossible to say that we're making progress. And I think we need to be able to show we're making progress. To Neil, to your point, have this momentum that is built up based on the events and the urgency and the dollars that we have sitting in front of us right now.
I might do a quick follow-up.
Jay,
go ahead, Meg.
Jay, I would say to you as a physician, following on Andy and Neil's comments, I would say in so many communities, it's still at the diagnosis phase, that you'd really like to have the core metrics. This is what we find as we work with communities, business, stakeholders, others, is not to gather 5,000 metrics. Mm-hmm. Or even start with the ROI, start with what's the prevalence rate? Are there particular conditions in this community that are really driving the overall medical spend, the time away from work, the lost opportunities affecting whole cohort groups? Is it a problem that you lack the correct number of physicians or specialists? Is it life expectancy? Is it food insecurity? Look at maybe 10 metrics that are available for your community, that are going to be available to you year after year after year, and against which you can compare, as always communities do, my neighboring community, the community in the next state, where I might lose residents to, I might lose business to, or I might attract from. So looking at those to do the diagnosis as to what are our issues, and then starting to think about what can we do, what interventions make sense, and then, as Andy said, how do you track the ROI on those? So I think it's kind of that fundamental getting the core data so that everyone kind of understands, well, what's happening here.
Yeah. And I'll add, if I could add to that, Jay, just quickly here. So Andy, I appreciate you putting that on the table, and just a quick nugget, and I'll double down on Meg's point. When we set out to do this paper, the first thing we did was to say, okay, who's looked at this math before? What are the numbers they cooked up, and do we agree? And to our amazement, no one had ever sized bias in the health system with a hard number. So after the paper came out, Andy and I, got a bunch of reach outs from a bunch of very interesting organizations. A couple of them wanted to get on the phone simply to thank us for the number. They said, I've not been able to get funding for my equity creating activity because I've not been able to size the problem, and nobody has sized the problem. And so to our amazement, we're essentially the first number out there that's sort of putting a stake in the ground and say, this is the size today, this is what it's growing to. That's remarkable point number one. Remarkable point number two, and this goes to your point, Meg, the math leaned on a set of data sets that were already out there. We didn't have to manufacture data to go do this. All the data was there. There's simply no one who put it together. And so to your point, Meg, go after data sets that are existing in your community that have probably been there and have longitudinal history and probably have a commitment to continue being produced, and just simply put the story together. And I think that applies for communities. Frankly, I think it applies for other stakeholders in the ecosystem as well, providers and insurers. They have the data. Our view is they're probably not pulling the equity-oriented insights out sharply enough. And that is a commitment and an exercise that I'd like to see more of from those stakeholders in particular.
I'm so glad you went there, because I was going to pose a question of what was compelling and new about this report. And I think you just hit the nail on the head there, that I think the lens by which we looked at the issues and pulled the data together had not been done before. But also, I think looking at particular communities and women and other communities in the context of the data. And I also would say that I have a strong opinion that we have the data. I mean, whenever there's a suggestion that we need to collect more data to address this issue, I think that's just hiding in some ways behind opportunities that are ready. And so the opportunities to ask the question. So, for example, a rural hospital in Georgia said, what's the difference between men and women who have diabetes and getting readmitted? It was 10%. Why should there be that difference? Right. So it's also saying, so what can we ask of the data we have to illuminate some of the inequities and then take action on it? So I think that that's an important piece, and that disproportionately impact on race and ethnicity. But we know that veterans are impacted, people with disabilities, rural communities, women, and also the LGBTQ population. And so you can segment and think about this data in different ways that are available. A lot of public data as well.
And Jay, an interesting nugget here is this double-edged sword, because in some instances with health data, we've purposely, as a society, not collected racial data because we didn't want to exert bias, by seeing certain patients were of a certain race versus not, right, or a different race. What's interesting, though, is that affects then your ability to then run the analysis to see if the bias is occurring across racial lines. So the gender dynamic I can look at in many instances, the socioeconomic data is there. The racial data is really erratic because in some cases we've purposely not collected it to avoid bias. The downstream impact might be that I'm not being able to isolate the bias that's occurring because I don't have the racial data at an individual level. So it's a complicated question in some instances.
Yeah. And I think there's two pieces, right? I mean, Jay, you brought up, I think, the data exists to identify how big the problem is. And maybe, Meg, to your point on metrics, where to start. I think what's interesting, Neil, on the point you bring up, which is I think where I was also trying to go, is this: to get the element of am I making an impact, we do have to change how no one's collecting at a healthcare data for sexual orientation, right? We're not consistent on race and ethnicity. And I think if we want to make meaningful change, we have to, one, be open to collecting it, also give ourselves time to find that data. It doesn't necessarily prevent us from starting because we have measures, we have data, we actually know places where we can start, Meg. And I think that was your point, right? Don't complicate the fact that we know we have some really significant problems. But I do think we need to be better at collecting it consistently so we know we're not ignoring issues that are out there as well.
Yeah, and that's such an important point, Andy. And we've done some work and have a report out about race and ethnicity data collection across commercial health plans. So I think this piece of disaggregation and collecting effectively and appropriately is work that we need to do. And there's a group of stakeholders together that can help make that happen. And I think as generational shifts happen, it'll be interesting to see what communities will self-report and what individuals will self-report.
Yep.
And then also putting a lens on the algorithms and the analytics so that we're not having bias that then leads to decisions that may be inappropriate or further exacerbate the issue.
Yeah, and I guess I would say something a little bit that might be regarded as heresy as an economist, which is I don't think we need perfect data.
Yeah.
And I agree with you very much for certain aspects, having much richer, more robust social determinants of health, racial, other kinds of data in with the fundamental data that's being used by health systems and others and researchers is really critical. I think for a lot of what we're talking about, even having, somewhat aggregate or zip code level data in terms of prevalence and some basic data to be able to align stakeholders around for action at the community level to, at a minimum, have awareness and motivation for action. I'll share with you, we did some work with a major entity outside of the U.S. that had looked at the work in Nashville and Buffalo, which quantified the productivity costs. And their comment to me at one point is, if we get it to $500 million, it's close enough. I don't need it down to 2 or 3 decimal points. So I think some of it also is what would motivate and be enough data, good data to get action now. Because that, I think, is the hardest part to go to, the challenge I think you're rightly bringing to us with your report, which is how do you get community members, individual stakeholders to take action now around these significant health inequities and disparities while we're working on the overall system to be addressing them as well. Be really interested in it seems like you've really engaged with a number of stakeholders to be able to do that. And I think that's a really key development.
And that stakeholder engagement is such an important part, to the point Andy was talking about earlier. This everyone has to come together, that collective action, so important to address this issue. And the 5 strategic steps that the report talks about as being intentional, sort of health equity by design, forming those cross-sector partnerships, measuring progress, addressing individual and community level barriers, and building trust, and that all of those happen to advance progress on this issue. And I know the National Forum has done great work in Move with the Mayor, or messaging that resonates with communities to help both public-private sector partnerships thrive and address some of these issues. So I think we need certainly more of that. But one of the areas that I know the forum's engaged in discussion around and is an issue is, state budgets as it relates to Medicaid. We know that health inequities certainly shows up in this area. From your perspective, how does health inequity affect state budgets, Medicaid, crowding out, taxes, and what could potentially be done there? And maybe I'll start with you, Meg, and have Andy and Neil kind of react to that.
Maybe to start, one thing I've seen is it certainly represents a significant share of healthcare costs. The health inequities and so on really do constitute a significant burden. One of the areas that I've seen, increasingly develop in the last even 6 months is the effort to have waivers that are really focused around collaboratives, healthcare-led collaboratives in states. New York has proposed one. It was just approved in Arizona. Oregon has, collective entities that are really focused around trying to address these specific kinds of issues. So I think that is an area to follow, to look to see where different kinds of interventions can be put into place. But to go to your point, the total dollar impact is enormous. And it is something that affects virtually every community. And it represents a significant proportion and a likely increasing proportion of state budgets going forward. And part of that is because of the individuals who are covered by it, but also the fact that the kinds of impacts that we're talking about, multiple comorbidities, additional complications, disease progression, access issues, there are fundamental issues that will continue to increase the reliance on that. We're having interventions that could improve health, improve outcomes, have different modes of care delivery. All of that would have, significant benefits if it could be developed.
And Jay, maybe as you think about examples too, where this shows up, we had done some work because we didn't know the number we were going to find when we actually did this report. To Neil's point, it had been over a decade since someone had even come out with a number, and that was very isolated to racial and ethnic bias. What's interesting is we then said, okay, we're funding this, wasteful spend because we haven't solved health equity yet. There's still systemic bias. What does that translate to? And this comes into, you're actually spending money on the inequities and bias that could go towards infrastructure, towards school, we had looked at it around student debt. Like there is so many other elements that as looking at your budget, whether, regardless of where that sits and saying, okay, we can actually shift that into more valuable ways in communities that probably need that. Yet we're spending that money here, right? Because you don't see it and we haven't addressed it yet. So I think the call to action is what could you get and invest into, because there are things that we probably leave on the table. The infrastructure is a great one as an example where that you, by changing and taking action here on health equity, will have the ability to influence everything else. Because it does show up I had mentioned before, in individuals and taxes, but at a state budget, at a federal budget, we see this number as an order of magnitude that's distracting away from other things that could be more critical for every single person. Neil, what would you add?
Nothing, actually. I think you both perfectly complementary. Meg, your point is it's increasingly a big portion of budgets and it's putting enormous strain on the system. Andy, your point is if we can go get it and rip some of it out, the benefit to your community is enormous because you can reapply those dollars elsewhere in really fundamentally helpful ways that your community values. So those are complementary points, and I think it's the main point.
I think it goes back to also if both government and the private sector organizations look at their own people and their policies, they can take action on this issue that will then return savings that they can reinvest. And as well as language, we haven't talked about health literacy, but even how you communicate benefits or opportunities to your employees can that language and the literacy level of it can have an impact on behavior and then outcomes.
And I think you put it so well, because it's really not about cost minimization. it really is, even as we've shifted more to outpatient care, as we're improving access and so on to overcome some issue, sometimes actual spend goes up. But the outcomes that occur maybe a year down the road or 2 years down the road, those outcomes benefit are huge in their impact and potentially in competitiveness and in terms of resiliency and prosperity for a community. So I think you're right, thinking about it more as how do we look at it collectively? And spend wisely, but spend in a way that allows it to be a real investment on outcomes. And that's something I think that's been hard, for us to be thinking about, and kind of where across the country it's having individuals in local communities kind of adopt that framework, but also maybe look to who's sharing that message with them, I would say, is the other part. Who's kind of saying it's important to think about this.
This thread of conversation for me brings up also another perspective that we can't apply standard ROI analysis to the issue of health equity because of the indirect benefits you have to account for, the long-term view and impact. It's a 3 to 5 year horizon as opposed to a shorter term horizon. And thinking about the population and demographic shifts, that has implications for that analysis too. So when we think about how do you analyze return on investment, you have to apply, I think, a set of different lenses to the standard approach. But I know we're closing up on time here. We've got about 5 minutes, and I want to come back to where we started with Neil's point of view on future of health. We're seeing alternative sites of care. We're seeing convergence, digital, virtual. How did those organizations and that ecosystem, think about addressing health equity? Where are the opportunities there? Because convergence only going to grow. Digital and virtual is only going to grow. Retail engagement in healthcare, and those, as organizations merge and partner, there's implications for health equity there.
Yeah, it's actually a very interesting question, James, and it's a mixed bag from my seat. So I would say digitally native organizations that grow up hyper-oriented on health tend to understand the equity question intuitively because a lot of their founders have been in this space and they understand the divergence in outcomes based on some of these bias elements that we've talked about. So I think you're seeing real progress with those disruptive ventures that are digital-born, healthcare-oriented. For digital-born, broadly focused organizations where health is just one of many verticals, it really depends on the leadership as to whether they understand this issue. And a lot of them are not native to the health space and don't have leaders that are native to the health space. So they wade in and they may be taking their cues from the incumbents in some senses. And my concern is they may be perpetuating some of the biases or orienting around the structures that actually lead towards differentiated outcomes. So that's a concern. And so I think that is different. What's interesting is a lot of these digital solutions, though, by their nature, address some of the bias in terms of access. I think what you're also seeing with some of these new entrants, in a very interesting sense, is for the first time you're starting to see really smart segmentation in health, right? Where the demographics and the preferences of the consumers play into how you show up delivering against the health issue. Whereas historically in the health system, a knee is a knee is a knee. Doesn't matter whose knee it is. It doesn't matter what your broader wraparound circumstances are. I'm going to treat the knee. But what we understand is that probably is not the best way to deliver care. And so you're seeing the emergence of organizations that are hyper-focused at a segment level. And you've got a number of organizations that are emerging now that are actually providing tremendous value in care and outcomes and are profitable serving the Medicaid population. So the running mantra that you can't, be profitable serving Medicaid is bogus. You just have to orient yourself around the needs of that community and deliver, at elite levels, and you can thrive as a business there as well. So it is a mixed bag. I think it's a running conversation, and my hope is that those organizations that do step into the space continue to get nudged by conversations like this and continue to put it to the fore.
It's great. Well said. And I think we're seeing, retailers and life sciences companies engage in the issue of health equity as well. From clinical trial diversity to supply chain to community investments. So that'll be interesting to watch. And so I'll close here with a comment from Andy and Meg. Any last thoughts that you have as we close up this conversation?
No, I'm gonna open or close, Jay, with where I had started, which I think is super important, and the reason why we put the numbers are so important. I mean, this is every single individual, every community, every organization has to play a role in here, and I think the numbers would tell you you're paying for it now, and so the time for action is now.
Great, thank you.
And I would conclude on kind of the same note as well. I think it's an incredible time that we're seeing coalitions, stakeholder groups form that are broad-based, that now have those trusted relationships in the community and the ability to collect and share the connected data. And I think even going back to your point on digital, opportunities for partnership and for having a portfolio of options, not just a single one, to really engage people around the how do we collectively improve health, well-being, mental health, physical health, and the healthiness of our community in which we live. So I think we're at a pivotal point, and I think having kind of these data to say it's important to do this is a great way to start and end this conversation.
Excellent, wonderful thoughts. And one of our discussants in the report, Pierre Theodore, an executive with Johnson & Johnson, explained that addressing inequities is a rising tide, all boats phenomenon. When you address inequities for one population, you raise health for all populations. And I think that that's well said, and that this is health equity is everyone's business. And we're so grateful for your contributions, Andy, Neil, and Meg, in this effort, and wonderful conversation today. So I just thank you all for all that you're doing, and thanks to the National Forum for elevating the conversation on this issue.
Very much so.
Thank you. Thanks for having us.
Thank you.
Thank you.